Hello, everyone. I'm Anas Al Ubaidi, and the title or the topic for this session is Behavioral Health Documentation and Standards. Um, and, it, and it is within Chapter 33 as of review of Psychiatry Scribing within the Certified Medical Administrative Assistant course program by ACMSO. Introduction. Behavioral health documentation plays a critical role in ensuring the quality and continuity of mental health care. Unlike physical health records, documentation in behavioral health requires a nuanced approach to capture the subjective, sensitive, and multifaceted nature of the mental health disorders. From initial patient evaluations to ongoing treatment plans, every note must be clear, concise, and reflective of the patient's unique needs and progress. For medical scribes working in this field, mastering behavioral health documentation standards is essential for supporting clinicians in creating accurate, legally compliant records while maintaining patient confidentiality. Behavioral health encompasses a broad spectrum of conditions, including um, mood disorders like depression and anxiety, severe mental illnesses such as schizophrenia, and behavioral challenges like addiction and eating disorders. Effective documentation ensures that all facets facets of a patient's mental, emotional, and functional health are captured. Additionally, it facilitates coordination across care teams, guides treatment adjustments, and provides a legal record of care provided. Importantly, behavioral health records must comply with stringent confidentiality regulations under laws such as HIPAA in USA, which is for personal data protection, or whatever is equivalent according to the country, location, or geographic area. Emphasizing the need for scribes to understand both documentation practices and ethical considerations. Key points: comprehensive behavioral health history, patient history as the foundation of care. Initial assessments here, behavioral health histories, are more than a list of symptoms. They include psychosocial factors, family history of mental illness, substance use, and major life events that may influence the patient's condition. Example: a 32-year-old male presents with a history of anxiety disorders since adolescence, exacerbated by a recent divorce and job loss. Chronicity and triggers. Documenting the duration and triggers of specific issues is important to differentiate between acute episodes and chronic conditions such as generalized anxiety disorder or bipolar depression. Cultural and social context. Um, Contexts include cultural attitudes toward mental health or unique social circumstances to provide a context for care. This aids in tailoring the treatment approach. Example: patient reports cultural stigma surrounding therapy requiring clinician-centered education about mental health. Importance of assessment tools. Standardized rating scales. Behavioral health relies heavily on structured assessment tools to quantify symptom severity and guide clinical decisions. PHQ-9 Patient Health Questionnaire, PHQ, which is short for Patient Health Questionnaire, evaluates depression severity ranging from mild to severe, directing treatment options. Example: a PHQ-9 questionnaire score of 15 suggests moderate depression, necessitating therapy initiation alongside pharmacological um, intervention. GAD-GAD-7 Generalized Anxiety Disorder Scale documents the frequency and intensity of anxiety symptoms, ensuring consistency over time. Functionality and symptoms. Tools like the Mental Status Exam, MSE, assess cognition, memory, attention, cognition, memory, attention, mood, and affect. Document findings comprehensively as patient alert, for instance, patient alert and oriented, mood depressed with constricted, affect, recent memory intact. Using scales ensures objectivity and allows providers or clinicians to track changes in symptoms longitudinally. And here's a diagram on standardized rating scales and behavioral health. Documenting and relay of treatment plans. Treatment plan integration, multimodal approaches. Most behavioral health treatments combine psychotherapy and pharmacological options. Scribes should document the specific methodology, as for instance, patient placed on 10 milligram escitalopram daily, plans for weekly cognitive behavioral therapy. Patient goals and progress, document collaborative treatment planning, focusing on patient driven goals. Patient, for instance, here, patient aims to reduce panic episodes to once per week and improve social interactions over the next 3 months. Monitoring and side effects. Record adverse medication reactions or therapy outcomes to determine treatment efficacy. Reports mild, uh, for instance, patient reports mild nausea during initial SSRI, selective serotonin reuptake inhibitor use, resolved after dose adjustment. And here is a diagram on visualizing comprehensive treatment plan integration. Navigating confidentiality in behavioral health, confidential records management. Distinct from other specialties, behavioral health documentation must comply with elevated standards of privacy. Avoid unnecessary details in records that may breach confidentiality unless clinically necessary. Use patient consent forms to document shared information with family or external parties. HIPAA and state laws. Behavioral notes subject to psychotherapy note. Um, Protections require additional patient authorization for release. Ensure clear labeling of sections. Standard progress note doesn't include therapist processing notes. Documenting crisis situations, instances of imminent risk to self or others. For example, suicidal ideation must be thoroughly documented with appropriate mandated reporting. For instance, patient expressed passive suicidal ideations, denied plan. Follow-up protocols and continuity of care, ongoing monitoring through structured notes, progress notes under the SOAP format, integrate subjective for symptoms, objective observations, assessment and plan sections for every visit. Subjective, we have reports, reduced panic symptoms weekly. Objective, less fidgeting and flat affect compared to prior visits. Assessment, anxiety to moderate control. Plan increase, cognitive behavioral therapy, CBT frequency, no medication adjustments proposed. Coordination across providers or clinicians. Mental health often intersects with other specialties, for example, primary care for anxiety-induced hypertension. Scribes must ensure details are communicated between teams, primary care updated regarding anxiety management strategies, future mid-sync explored. Tracking across visits, ensure clarity in tracking patient progress longitudinally, emphasizing changes in functionality, medication adherence, or therapeutic breakthroughs. Summary tables. Here we have table on common symptoms in behavioral health and key documentation notes. Table on behavioral health assessment tools and their utility. Table on treatment options and follow-up approaches. Table on confidentiality and ethical documentation practices. Table on follow-up and progress monitoring strategies. And then we will revise what we have covered via this lecture through some MCQs or multiple choice questions. Question 1. What is the primary purpose of mental status exam, MSE, for short, in behavioral health documentation? A, to evaluate physical symptoms related to mental health. B, to provide a structured assessment of cognitive and emotional states. C, to replace standardized tools like PHQ-9 and GAD-7. Or D, to determine medication dosage adjustments. It is B, as to provide a structured assessment of cognitive and emotional state. The MSE evaluates areas such as mood, affect, cognition, memory, and orientation, providing a comprehensive view of a patient's emotional and cognitive functioning. Question 2. Which of the following documents requires elevated privacy measures and additional patient consent prior to being shared? A, standard progress notes. B, prescription records. C, psychotherapy notes. Or D, referral letters to primary care. It is C, definitely psychotherapy notes, as psychotherapy notes are subject to enhanced protections under HIPAA and typically require explicit patient consent before sharing. Question 3. A patient's PHQ-9 score improves from 18 to 9 after 6 weeks of treatment. How should this be documented? A. Not only the improvement in mode without reference to scores. B. Record the numerical scores without linking them to patient history. C. Integrate the improved scores into the treatment narrative within context. Or D. Document the score improvement but leave out future treatment adjustments. It is C. The answer is C, as behavioral health documentation should connect assessment scores to the treatment narrative and patient history, showing improvement over time and informing next steps in management. Question 4. Why is it important to document specific symptoms of suicidal ideation, such as passive versus active ideation, behavioral health notes? A. To meet legal requirements and ensure mandated reporting when necessary. B. To prioritize medical over therapeutic interventions. C. To avoid over documenting sensitive patient details. Or D. To reduce the need for follow up care. It is A. To meet legal requirements and ensure mandated reporting when necessary, as suicidal ideation must be clearly documented to guide risk management, establish mandated reporting when needed, and determine the appropriate intervention route. Question 5. Which standardized tool is most appropriate or proper for screening substance misuse in behavioral health documentation? Is it A, PHQ-9, or B, Gauge Questionnaire, CAGE, or C, GAD GAD-7, or D, MSE? It is B, Gauge Questionnaire, as Gauge Questionnaire is specifically designed for identifying substance use disorders. PHQ-9 and GAD-7 are used for depression and anxiety, respectively, while the MSE provides an overall assessment of cognitive and emotional health, but does not focus on substance misuse. And here we come to the end of this lecture. Thank you very much and goodbye.